Well, thank you, everyone, for coming. It's a pleasure to have you all here. It's my pleasure to be here. My name is Evan Eiler. I'm on faculty here. I'm a professor of psychiatry and family medicine. I've been working in trans health since 1995 and have published and taught on it in a variety of venues, so this is something dear to my heart. And it's a pleasure to have three colleagues with whom I'm very pleased to be presenting tonight. We seem to have a little feedback, and so Michelle is coming to rescue me. Is that better? No, that's too little. This is like the three bears. Okay. Is that the right bear? Okay, good. All right, so I'll tell you a little bit about my colleagues beginning left to right there. Kate German is the director of the LGBTQA Center here at UVM. She holds a bachelor's degree in social work from New York University and a master's in public health with a focus on LGBT health from Columbia. She was a founding member of the Pride Center and served first as staff and then as co-executive director for Outright Vermont from 2001 to 2008. So she was youth age herself when she was handling all that responsibility and doing all that good. Before returning to Vermont in 2017, she was an advocate for inclusive and affirming programs and policies for trans people and communities in the San Francisco Bay Area. Eli Goldberg is a student here at the Larner College of Medicine and will graduate with an MD in the class of 2020. He is a co-leader of the college's Gender and Sexuality Alliance. He has been an Albert Schweitzer Fellow here and played a pivotal role in the Transform Project, which is a peer mentoring network statewide based at the Pride Center. And he has presented 3 times at the annual Translating Identity Conference in Burlington, and also at the College of Nursing and Health Sciences. And Lola Houston is a sex and relationship counselor based here in Burlington. She is a standardized patient at the medical school here. She received her graduate degree in anthropology at McGill. She's a member of Phi Beta Kappa and the Anthropology Honor Society Lambda Alpha. She has taught anthropology, sexuality, and gender studies classes at St. Michael's. She is a 5-time presenter at the Translating Identity Conference here in Burlington. And she has taught a variety of sexuality-centered workshops at Sterling College in Craftsbury. And she has been on the podcast Loving Without Boundaries. So it's my pleasure to listen to what my colleagues have to say, and at this point, I'll cede the floor to Kate.
Hi, everyone. It's my pleasure to start us off tonight. I was asked to speak first today and provide an introduction to some of the language that is a foundation for our conversation, as well as provide some insight into the ways that institutions are changing to better serve transgender people, and I'll give some examples of my work at UVM. I want to preface what I'm saying tonight with 2 important points. I've been fighting for trans inclusion and equity in healthcare and other large systems for many years, and always from the position of being a white cisgender ally. My opinions are in no way a replacement for or better than listening to the actual lived experiences of trans people themselves. Second, in every conversation about transgender health and healthcare, it's difficult not to focus on the risks, the harms, and the negative experiences. I want to say right from the beginning tonight that trans people have always and continue to create vibrant communities and brilliant strategies of resistance to counteract the violence inherent in the binary world that we currently live in. So let's start with a broad definition of gender. Gender is a complex system of roles, expressions, identities, and performances, and more, that are given gendered meaning by a society and usually assigned to people based on the appearance of their sex characteristics at birth. How gender is embodied and defined varies from culture to culture and from person to person. and I would add might vary over time as well. It's important to start from a shared understanding that gender affects us all and that everyone has a gender identity and not just trans people. This next slide breaks down that definition a little bit more. Forgive me if this is too basic, but I think it always helps to start from a shared foundation. So gender identity is how we feel. It's our sense of ourselves as a man, a woman, or something else entirely. Sex, or sex assigned at birth, is what we were assigned at birth based on the parts that we have. Sexual orientation is who we love. It's not as relevant here or to tonight's conversation, but often when people are first learning about gender, this is one of the terms that gets confused or thrown into the mix somehow, and I find it helpful to separate those out from the start. Obviously, there are much more nuanced layers to each of these concepts, but this is a helpful place to ground our understanding together. This next slide gives some additional definition for terms that we use frequently when we're discussing gender. Terms like gender binary, trans or transgender, cisgender, genderqueer, and transition. I'm not going to spend a lot of time here, but this might be a helpful slide for some folks to return back to, and these slides will be available after the presentations. They'll be available online. Just a couple things to note here. When we talk about the gender binary, we're talking about the categorization of gender into two distinct and opposite sexes, and it's very much about the system we live in, where we're raised to understand that there are only two genders. Those are the boxes, and those boxes have very distinct lines. Fighting that, challenging that, I think is one of the most important things that we can do when we are fighting for gender equity and gender inclusion, but knowing that kind of that's the water that we're swimming in is a helpful place to start. And also cisgender, which I used myself when I introduced myself, someone who identifies exclusively as the sex they were assigned at birth. So rather than saying a transgender person and a not transgender person, we would say transgender person and a cisgender person to describe someone who identifies with their the sex they were assigned at birth. Okay. So there are also lots of other terms, and we'll take questions at the end if there's language that you're not seeing here. But these are often the terms that we get the most questions about. Okay, so one final note about language, pronouns. Referring to someone by the correct pronouns is one of the easiest ways to be inclusive and to show respect. It's becoming more common to hear people explicitly state their pronouns, for example, when they introduce themselves, or you might have seen some folks starting to include their pronouns in their email signatures. If you work in the UVM community, you've certainly seen that trending on the rise. The intent behind this gesture is to avoid having to make assumptions about someone's pronouns based on their physical appearance or their gender expression. If you aren't sure what pronouns someone uses, it's better to ask than to make an assumption and potentially misgender that person. And most importantly, if you make a mistake, apologize and move on. One last thing about this slide, some folks, I think the rise, when pronouns really started to expand and more inclusive language became more common to hear, the pronoun Z was often a popular gender-inclusive pronoun. I would say far and away, they, them as a singular pronoun has dramatically eclipsed use of other gender-inclusive pronouns, but these are some of the ones that you might hear or see or be in contact with, I guess, in your daily life. Okay, so shifting gears a little bit to the way that UVM has changed some of its systems to improve the health and well-being of trans people in our larger community. We have changed the CAT card system, which are our ID badges, so everyone, students, faculty, and staff, have the ability to go in and make changes there. So legal name changes as well as preferred names to go into the system, and that really is kind of the master system for identification on campus. We also allow changes to our student information system so that in places such as name decks that go on folks' housing assignments or on class rosters, someone's preferred name and their pronouns will show up there so that they don't get misgendered or called out by a name that they no longer go by in the classroom. We also allow folks to change their email address and the alias that is attached to that so that you're not inadvertently outed by your email. We have a lot of gender-inclusive housing options, and it's probably the easiest that it ever has been on campus to find information about the bathrooms and shower facilities in the residential buildings. So for incoming students especially who are required to live on campus, students have to live on campus for 4 semesters, they can include that information when making their housing selection. We have gender-inclusive restrooms and locker rooms in athletics facilities. That's probably one place where we could still use some significant improvement, but the facilities do exist. We have insurance coverage and healthcare services, so everyone on campus, I guess what we commonly call trans-related healthcare is covered in our insurance riders, and also students who are seeking medical transition or medical care as part of their transition can access that in our student healthcare services, as well as in our counseling and psychiatry services. And then the one on the bottom, expanded restroom options in all campus buildings, that's been a huge push, and it's been a really long time coming, but now on campus, all single occupancy bathrooms are gender inclusive, so you'll never see a sex-specific single occupancy bathroom, and our goal is a range of bathroom options in all campus buildings. So to the extent that it's possible in every building, we try to have single occupancy bathrooms, gender-specific multi-occupancy bathrooms, and gender-inclusive multi-occupancy bathrooms. And if you're looking at this list thinking like, oh, you know, like that's not that big of a deal, or yeah, we have that in my workplace too, I just want to revisit where we were when all of this started. So as I was preparing for this presentation, I was looking back at what UVM had done and when it did it. And it wasn't that long ago that there were no protections for trans people. There were barely any out trans students on campus. There was one trans staff person on campus, and I'm comfortable saying there was one because I was talking to that person in preparation for this, and just revisiting how far we've come in such a short period of time. So it wasn't until 2003 that Vermont adopted gender identity non-discrimination in state law, and it was the same year that UVM organized to add that to their non-discrimination policy. And it wasn't that the university decided, like, this is a great thing, let's just do it. Students really pushed for it. So like a lot of things on campus, it rose out of student activism. It was really powerful, and they got that change made. So a lot has happened since then. We still hear, I think, the sticking points for students and the common needs that we still hear a lot about are students feeling misgendered across campus, not being referred to by their correct name and pronoun. There are still significant safety concerns, and they need somewhere to pee. So hopefully we're working on that last one, but a lot has changed in terms of access to resources and where on campus they feel affirmed. So looking back at some reports that were written in 2002 about what UVM could do to be more inclusive of trans community on campus, we have made some significant strides, and now accessing the services that you need to be a successful student, you won't find the barriers that were in place back then for trans community. I also just want to note that a lot of these benefits, they were things that we did because it was important for trans inclusion on campus, but they really had a benefit for everyone on campus. And the example that I like to use is what's going to happen when the athletics complex has multi-occupancy, gender-inclusive bathrooms. The line at games, especially for folks who are used to using the women's room, is going to be incredibly short, and it's going to be amazing. And I say that somewhat jokingly, but really, we tend to think of things that are done for this community, and it only benefits the community. And I think when we're working on gender inclusion especially, it has tremendous benefits for so many people, not just trans community. And we need to keep that in mind more often. Also, work that still needs to be done, and I hope to see happen on campus. I think we could do a lot more to, cutting myself off. We could do a lot more to not have gender segregated spaces, or to make decisions about how people interact with our system based on gender. It's kind of an artificial construct that I think we do a lot of, but the university could change. And also more work at the intersections and recognizing the compounded effects of oppression on people with multiple marginal identities. And the example that sticks out for me, especially on our campus, is the experience of trans women and femmes, and trans women and femmes of color especially. So thinking about the intersections of those identities and how we organize and improve our communities to lift up the most marginalized voices in particular. And I'll just end by saying that despite an increase, I think a tremendous increase in visibility for trans community in the last several years, the rise in pop culture references and visibility for select members of trans community, there's been no attendant shift in power or in access to resources. And so when I think about the work that we do in the university to be inclusive of our trans community members, I think really what still needs to happen is that shift in power and access to resources, and kind of all of the benefits that higher education, sorry folks are going to talk more about medicine, but obviously I'm grounded in higher ed, and how we shift those resources to better benefit the community as well. So I will stop there, and I'm happy to take questions about anything that I've shared tonight at the end. Thank you.
All right. Can everyone hear me okay? Yep. Okay, great. So my name is Eli. I'm a student at the medical school. I have had the good fortune to be able to navigate the healthcare system, first as a trans patient, and now to go back and see what it looks like on the flip side as a medical student. So in the next few minutes, I'll be giving, hopefully, a brief overview of the medical options that are available for trans people. And I also want to try to give a sense of what the experience of accessing healthcare can be like for trans folks in this system. So starting with a few basic points, for many trans people, access to gender-affirming healthcare is absolutely critical in order to be able to live in society and be perceived in a way that's consistent with our actual gender. And we know that when people have access to gender-affirming healthcare, there's significant improvements in terms of mental health and functionality and overall quality of life. And for that reason, it's been accepted as the standard of care, and it's now viewed as medically necessary treatment by most major medical and professional associations. There are protocols and guidelines out there for how to provide gender-affirming care. The most widely used set out there is the standards of care that are put out by WPATH, the World Professional Association for Transgender Health. Those standards have been around for a couple decades now, and they're currently on the 7th version, so they've evolved a lot over time. That said, even though we have these sets of guidelines, there's not a standard roadmap for medical transition. So I'll be talking about medical options along this progression that kind of starts with engaging with the mental health system and then involves hormone therapy and possibly one or more surgeries. But this isn't a prescribed sequence. So many trans people don't want or need all of these interventions, and plenty of trans folks opt not to pursue any medical intervention at all. So I do want to make sure it's clear that although I'm talking from a medical perspective, there are plenty of valid choices that people make about whether or not to pursue pursue medical gender-related care, and those choices have nothing to do with the validity of their gender identity. And the final piece that I want to plant in people's minds before we move on is that I'll be speaking from a very medicalized perspective. I come from a world where people come in with a problem, they see a healthcare provider, hopefully we can attach a diagnosis to the problem, and then we move forward with a treatment that corresponds to the diagnosis. And for better or for worse, that's the way that we've kind of shoehorned gender-affirming care into our healthcare system. But many trans people look at that model and say, this is really pathologizing. This is not an illness or a disease, this is my identity, it's who I am. And certainly the process of coming out and transitioning for trans folks doesn't have to be a medical process at all. So although I'm coming from a medical world, I don't want us to lose sight of the fact that that's not the experience that all trans people have. So for many trans people, the process of medical transition starts with engaging with the mental health system. And historically, the standards of care required people to go through a certain duration of psychotherapy before they could access hormones or surgery. And that was often paired with a certain amount of real life experience, which was time spent living full time in a social role that was congruent with your identified gender. And those were guidelines that came about largely at the request of surgeons and other providers who were treating trans patients and wanted some way of making sure that their patients were really ready to kind of undergo this treatment and face the transition process. But to a lot of trans people, that looked more like gatekeeping. And one might reasonably ask, if someone's been pretty stable and secure in their gender identity for several years, do they really need to go through months and months of psychotherapy before they should be able to access hormones? So how much is this benefiting patients, and how much is it becoming an obstacle for people to access care? And the perspective on that has shifted a lot over the years. And in the current model, mental health providers play a role that's less therapeutic and more evaluative. So psychotherapy is no longer required for trans people to access care, but it is something that's still encouraged and that a lot of trans people take advantage of because it can be really helpful as a source of support in kind of clarifying needs and goals and navigating the ups and downs that go along with gender transition. And I do want to mention that coexisting mental health conditions like depression or substance use disorders are not a contraindication to pursuing gender-affirming care. They just need to be managed appropriately. Starting hormone therapy is often a big step for trans people in terms of beginning the process of medical transition. And when I talk to people about what it was like for me to start taking testosterone, I like to refer to the moment in The Wizard of Oz when Dorothy crash lands in Oz and she leaves her house, and suddenly the movie, which was all in black and white, goes into this beautiful technicolor. And for me, that's what that experience was like, that my life had been in black and white, and all of a sudden I was seeing the world in color, which I hadn't realized was possible before. So this can be a really huge step for people. It's a popular misconception that people need to see an endocrinologist in order to access hormone therapy. It's actually well within the scope of primary care. So if someone is seeing a primary care provider or a family doctor who's comfortable providing this kind of care and has experience with it, they don't need to go off and see a specialist in order to access hormones. The basic effects of hormone therapy, in addition to making the world burst into beautiful technicolor, is to support the development of secondary sex characteristics that are perceived as masculine or feminine. So trans men and trans masculine people may take testosterone. Trans women or trans feminine people often take estrogen, which may or may not be combined with an anti-androgen to block the effects of testosterone. That used to be pretty standard, but the side effects of anti-androgens can be pretty unpleasant. So the thinking is shifting about whether that should be recommended or not. And you can get a sense from the slide of what some of the effects of hormone therapy are. Some are reversible, the ones that are underlined are irreversible. And I do want to be clear that the underlined irreversible effects, if someone has experienced those during their first time through puberty, that can't be reversed by cross-sex hormone therapy later on. So for example, a trans man who went through puberty and grew breasts is not going to see those disappear just by taking testosterone. Many trans people will take hormones for life. Others will take them for a short period of time until they see the changes that they need to see in their body. And some people choose not to take hormones at all, and those are all valid options. I also want to mention that puberty suppression is an option for youth who are trans or questioning, and that's basically endocrine treatment that allows us to hit the pause button on puberty. So for adolescents, that can buy some time to really figure out what their identity is, how they want to be in the world, and ultimately make the choice that's going to be right for them about whether to move forward with their body's pre-programmed puberty or end up pursuing hormone therapy after all. Surgery is often the piece of medical transition that people are most curious about, and the concept of the surgery tends to loom large in the popular conception of what it means to be trans. And the reality is that there's really no such thing as the surgery that magically changes your sex. There are a variety of different surgical options that people can pursue. So for trans men or transmasculine people, that might involve mastectomy, which is removing breasts, hysterectomy and oophorectomy, which is removing the uterus and ovaries, or metoidioplasty or phalloplasty, which are different genital surgery techniques that create a phallus. And then for trans women or trans feminine people, breast augmentation is an option, orchiectomy, which is removal of the testes, vaginoplasty, which creates a vulva and vagina, and facial feminization surgery. And few people are going to go out and have every single possible surgery that's available to them. People pursue different combinations of these procedures, or none of them at all, depending on what they need in order to be comfortable in their body. Some of these procedures are relatively easy to access. Any gynecologist can do a hysterectomy. It's not that much different on a trans man than it is on a cis woman. But genital surgeries are quite complex. There aren't that many surgeons out there who perform them. They often need to be done in multiple stages. And around here in Vermont, it's not unusual to hear about people who've had to travel as far as Texas or Arizona or California in order to access surgery with a surgeon who's really well trained and experienced in these procedures. And the big thing that people are generally curious about is, how do they make it, what does it look like, and how does it work? And those questions obviously get pretty delicate and intimate pretty quickly. But what I will say is that we've consistently found that for people who choose to go ahead and have these procedures, even though they're complex and the potential for complications is high, the satisfaction rates are also very high. So they're doing what people need them to do. And I don't want us to lose sight of the fact that trans people also have all of the same healthcare issues as cisgender people. So we have cataracts, we have gastroenteritis, we have skin cancer and MS, and we break bones. So although we often think of trans care as being its own little bubble of healthcare, the reality is that trans people need all kinds of healthcare. And so every healthcare provider, no matter what area they're working in, needs to be comfortable working with trans patients, even if they have no intention of going out and providing specifically gender-related care. And unfortunately, our healthcare system often has not done a great job of accommodating trans folks. So the statistics that are up here are from a study that was done in 2015 by the National Center for Trans Equality. And what they found was that among the respondents who were based in Vermont, within the past year, 29% had had at least one negative experience with a healthcare provider, which ranged from being denied care all the way up to being physically or sexually assaulted in a healthcare setting. And 27% had had problems with health insurance, either being denied coverage for transition-related care or being denied coverage for routine care that had nothing to do with their gender because they were transgender. And I should say both of those insurance-related things are illegal in Vermont. They were illegal in 2015, they're illegal now. That doesn't mean they don't happen. And the fact that those things are illegal here puts us ahead of 38 other states that don't provide those kinds of protections to trans folks. And in the national version of the survey, 9% of people reported that a healthcare professional had tried to stop them from being transgender. And so maybe it's not surprising then that in the past year, 12% of these people had not sought out healthcare that they needed because they were concerned about experiencing discrimination because of their gender. And 60% were not out to at least one of their healthcare providers, which to me as a medical student is shocking, and to me as a trans person makes perfect sense. And I want to link this to the concept of minority stress. So when you're part of a social group that's widely targeted with prejudice and discrimination, you begin to internalize that stigma, and you start to modify your self-image and your behavior around the expectation of encountering rejection. So even though we've made a lot of progress in healthcare and in society, These past experiences of discrimination create an expectation of further discrimination that becomes a barrier to accessing care in the future. So from a healthcare provider perspective, we need to work extra hard, not just to not be bad, but to make sure that we're actively welcoming and affirming trans patients who are coming in expecting these negative experiences and being braced for them. And I want to wrap up by sharing 2 quotes. These are from a survey that was done in 2016 that I was part of, asking trans Vermonters about their healthcare experiences. So on one hand, we get stories like this. I met with a specialist to have a procedure unrelated to my transition. I was constantly misgendered, and the doctor made a bunch of assumptions about me, my body, and my partner. I still need this procedure, but I don't feel safe seeing that doctor again. I'm reluctant to go to another doctor for fear of having a similar experience. And on the other hand, we get stories like this one. My doctor and her staff were my training wheels for interacting with the world as a trans person. They were familiar with the transition process and very respectful, so I really relied on them for support. Starting hormones literally saved my life. My mental health is so much better, and my life is richer as a result because I don't have this weighing me down every day. And I don't mean to present these quotes as bad doctor versus good doctor, because we all go into medicine wanting to be that second doctor who's able to provide life-changing care to patients. And we all know that that's the doctor that every trans person deserves. But many doctors haven't been prepared to do that because until recently, there was nothing in the med school curriculum about how to take good care of a trans patient or how to avoid putting your foot in your mouth in the process. So for a lot of doctors, this is something that's just new and unfamiliar, and they haven't had the opportunity to learn. And we're making progress on that, not as quickly as I'd like to, but pretty darn quickly, in large part because of trans folks who've been willing to come forward and share their experiences in order to help educate doctors and medical students so we can do better in the future. And on that note, I'm going to hand things over to Lola.
Can you hear me? Yes. In the back? Great. Let me just start my little timer so I don't go over. Oops. Get a little buzz here. Can you still hear me? Good. Okay. Thank you for being here. This is an important and I think sometimes difficult topic. I'm going to offer a personal perspective that's based on my own experience. And the first thing that landed on my doorstep when I was thinking about this was learning to push past my own fears. How do I find acceptance as who I am? And maybe more importantly, how can I actually learn how to get out of my own way? My transition decision hinged on a number of factors. First and foremost was my own physical health. I had had bladder cancer. And I had no idea if mixing hormones and cancer was a good idea or not. Would cancer return if I took the hormones? And at that point, a little over 4 years ago, I had very little data to actually turn to. It was a small Swedish study that provided the break that I needed to get me over this particular question in my lexicon. I also had a personal life. I had family, I had partners. The loss of family is one of the most common narratives that I hear for trans persons. Many of us are completely 100% disowned by our entire natal family and never have contact with them again for the rest of our lives after we transition. I also have deep, loving relationships that I didn't want to lose. This can also be a very common narrative for trans persons. They have a relationship, they change, and it goes away. Both of my partners first knew me as the male that I was born into. I had no idea if they would stay or go. But I did make a decision to transition because I too had to try to save my own life. And a lot of new fears suddenly appeared. It didn't get better right away. My first encounters with the medical system were fraught. I had therapists that helped me make that jump to light speed. And I was really fortunate because I found a therapist who was very gentle and very compassionate here. They had to encode into the system my condition, which at the time I made this choice was called gender dysphoria. The American Psychological Association, or APA, had only changed this in 2012 from GID, or gender identity disorder, to gender dysphoria. And even despite of that, I knew that some of the providers that I would continue to see would continue to think me as mentally ill. Then there was stepping into a doctor's office, because I had to select completely different doctors for this process. I didn't know anything about these people, and it was a huge unknown for me. And unfortunately, I had a lot of baggage about what I might find based on my own past. Since then, I have been blessed with some excellent and compassionate medical care, and I am very lucky. But I'm quick to point out that this is the broad exception and definitely not the rule. The vast majority of trans persons struggle to find medical care at all that they can even pay for. And most of them encounter hostility and poor advice when they do. When I started this, before I started this, I was actually part of the standardized patient program here prior to my transition. So I had a sense of some of the problems that I would face in this domain. The SP program helped me recognize some of the limitations of doctoring. Most people have an initial discomfort around an encounter with a trans person. They need to navigate some basic questions, like, who is this? And for some people, it's so baffling that they sort of find themselves asking, what is this? And I realized in the SP program that, and I knew this, of course, but I learned it in a different way. Doctors are people too, and they have this exact same level of discomfort. Medical students, and I'm sure there are a few of you in this room, are often overwhelmed by input and expectation, not to mention a lack of sleep. We cannot expect these people to just know what to do. They need to be trained, and they need to develop understanding. So I made this decision, and I began my transition, and I found that transition moment. And I loved Eli's description from Wizard of Oz, and I'm so going to steal that in the future. Because I can still remember the day and the time. It was 5:09 p.m., and I put that first estradiol patch on. And apparently this is a very common experience. You have this transition moment. And that first patch was a huge rush of emotional relief for me. And I told myself, I feel different after 15 minutes. Yeah, you can see I'm totally different. Which is ridiculous, because very few medications will make you change that quickly. And also at the time, I remember having this awareness of other things that were going to show up, the social consequences, and that was a very visceral realization for me. Now that I'd started, I was beginning my post-transition experience. Welcome to the world. It wasn't all bad. My family was still there. I've had some rough edges. My kids were the place where I was really mindful, and I learned where I did and did not want to draw the line. I had a choice as to how far I wanted to push that edge, and I had to realize that they knew me growing up as a completely different persona, even though inside I'm exactly the same person that I was. I'm silly, I'm playful, I'm annoying, I'm a good cook, I'm a good musician, I'm all those things. None of that has changed. My relationships are still there. They're very deep and they're very strong. Both of my partners are actively engaged in understanding and exploring and being curious, and lots of love. I've had some negative experiences, and some have been extraordinarily painful. I was at a weekend workshop in Philadelphia, and I got into a conversation with a large group of people. And with one woman in particular, wound up calling me the interloper. And that really, well, for her, was about personal safety, because the conversation was about bathrooms, which was a big deal at the time. And she told me outright, I would not feel safe if you were in the bathroom. And it was instructive for me, because I realized that not only do most people have no idea who we are or accept us as we are, most of us suppress that outward expression of that discomfort because we don't know what questions to ask and we don't know how to ask them. And that acts as a huge barrier to questions and understanding. At the time, bathrooms, as I mentioned, was a huge issue. The politics of pee, which is a flippant, non-existent problem, because there is no substantive evidence whatsoever that we are some sort of dangerous person in a bathroom. It still took me a long time to get past that. It's disguised as some safety thing. But I have learned that there are limits of where I know I cannot go. And this is just for me, because every one of us is different. The most recent one has been open changing rooms. Understanding and honoring the nature and importance of safety amongst women and for women has been a very important part of my experience. And it presents me with this really difficult dichotomy, which I haven't resolved yet. It's been made harder by the Me Too reckoning. It's made it more challenging, and it's impossible to simply ignore that. New challenges continue to show up. I'm still seeing different doctors for different reasons because, as has been pointed out, we have health problems just like everybody else. And every time I see a provider, they have to jump through the hoop of the new me as not male. Not all my previous providers were involved with my transition. And not all providers certainly are even familiar with trans populations. We're still a tiny, very small minority of people. We don't really know what the numbers of us are. As a coach, I encounter people on a fairly regular basis that have uncertainty around their gender. Do they count? Maybe. We're also highly variable, something that I learned deeply from my friend Kate Bornstein, who pointed out that the trans experience is a spectrum. None of us have the same experience. And not all providers that you see have a comfort zone, because enculturation pervades every single one of our lives in ways that we can't anticipate or expect or even unravel. For a first-time encounter, they're often, the provider, are on the spot because they have to cope with the unexpected, and that can be a real challenge. They have to make assumptions about gender based on what is visible or what is seen. Things like voice. In my case, it's pretty obvious. Face might not be so obvious. Hair, we're not even going to talk about that. Mannerisms. I'm still unlearning a huge amount of what it was to be male, and I'm relearning even more about what it is to be female. And then there's politics. Every single day, the political climate seems to add some daily layer of pain and fear and awful. And I keep stopping and asking myself, why do they hate us this way? We haven't done anything wrong. It's not like there's an army of angry trans people marching across the wasteland of Kansas in an attempt to slay the Senate. We're often a political football used to advance other unrelated political and personal agendas. I've made it an intentional choice to be as out and as visible as I possibly can. I recognize that this often can push boundaries. I have my own sense of what feminism is, and I have the understanding of what it is for others. But it raises difficult questions. Am I woman, or am I something else entirely? I don't have an answer. I don't know how to reconcile my beliefs about what it means to be female with what I have embraced. There's also the fear of cis persons, cisgendered persons, Sometimes I feel like I'm a threat to their system. But in the end, I feel strongly about it because I want to be a role model for all the others who are fearful. And believe me, there are a lot of us who are petrified. And the lack of visible role models is a very big problem. But there have been a lot of positive changes for me. Chief among them, no surprise given what I do, sex and sexuality. It's completely new, it's completely different, and it's completely wonderful. Believe me, half of you in the room don't know what you're missing. The experience has changed considerably, but I continue to notice the abundance of tragedy for many trans persons around sex and sexuality. But now I understand the experience of sex from an entirely different perspective, female. My needs and desires are still exactly as they were. They're just better. Everything is completely normal. Depends on who you ask, but for me, it's normal. It leads me to wonder about one thing: what is sexual orientation in this context? And I have no idea. Am I queer? Am I lesbian? Am I gay? Am I bisexual? Does it matter? Overall, I will say that I am much happier than I was today, 4 years ago, before I started this. I still struggle a lot, as my partners will attest. The joy of hormones never sleeps, and sometimes neither do I. I work really hard on being me. I'm learning all the time, and I would not go back on this decision ever. Thank you for listening.
Okay, we've been through the moving, and now we're going to go back to the medical. And I would also mention, I realize in an audience this size that there are some people who are interested in medicine specifically and some in other healthcare fields. And I think everything that I'm going to say, I'm seeing people not hearing me, so I'm increasing the volume a little bit. Is that better? Okay, great. We're going to go back to the medical. And I just want to say that everything I'm about to say is applicable to other health fields as well. In an audience this size, there are probably nurses and social workers and psychologists and people in many other fields. I've taught in programs in a variety of disciplines. I've worked with people in a variety of disciplines. And I found that when it comes to trans care, that one is not better than another. That all the problems that exist in medicine exist in nursing and social work and psychology and elsewhere, at least to my observation, and all of the victories and triumphs do too. So we're in the same boat, let's do it. I did family medicine for 16 years, then a second residency in psychiatry, but my perspective is still one of care across the lifespan, consistent with family medicine. So the first thing that I will say is that trans people come out at all ages or are identifiable at all ages. Some kids are strongly gender nonconforming. Of the group of kids that seem different than their peers, and oftentimes this is obvious to parents, that someone will say, you know, I thought I had two boys, but it turns out that I have a boy and a trans girl, and you know, they were different from when they were little tiny, and I can't think that I parented them that differently, you know, that sort of thing. That some kids will be identifiable early on, and of that population, some will transition and some will not. Of the group who do not transition gender, who stay with the birth-assigned sex and gender, the chances are higher that they will be gay, bisexual, lesbian identified than their peers who are less gender nonconforming. However, any outcome is possible. You know, any kid can grow up with any gender identity or any sexuality. We just don't know. Adolescence can be a time that is either very scary or very affirming. That being said, it's adolescence. Raise your hand if you really enjoyed puberty. All right, I didn't think so, okay? So for people for whom the puberty is appropriate, their hormones are taking them in the right direction, there are enough difficulties, and I see a few nods there. For people for whom this is not the appropriate puberty, feelings of dysphoria, i.e. deep discomfort, increase. The train is moving down the track, picking up speed in the wrong direction. And at that point, people often need medical intervention and social and mental health support in order to not become depressed, despondent, suicidal, etc. Some people will come out as trans or will transition in young adulthood, middle adulthood, older adulthood. One of the questions that I often get is, well, okay, if the world were really egalitarian and anyone could have any gender identity and any gender expression, would you see people coming out in older adulthood and transitioning then? And I can only say, well, first let's make that experiment and find out. Let's just do that. But since we're not doing that, I have to speculate. And I think that the answer is probably that more people would be comfortable transitioning at younger ages, but there would be some who would at older ages, because we learn about ourselves on our journey through life, just as we do in many other areas. That being said, people seek medical and mental health care at all ages, and the challenges they face when they're coming out at younger ages versus older ages are in some ways reciprocal. For people who need medical gender transition services, they need to take hormones, younger is in some ways an advantage. That if someone realizes at a young age that this is the puberty that they are biologically going to have without intervention is not the right one, and are able to use puberty suppression for a couple of years, let cognitive and emotional maturity catch up a little bit, and then go ahead and use hormones, they're going to have, on average, everyone's different, a more natural appearing physical result, because puberty has not gone in one direction and then had to go in another direction. It just goes in one direction. They'll also have opportunity to do things along with same gender peers that they otherwise would not. You know, join the boys' Little League, join the Girl Scouts in the right gender presentation for them. That being said, they have challenges too. Lack of life experience makes things more difficult. It's not uncommon for young people who do not have adult-level coping skills to be more easily overwhelmed by challenges having to do with being trans or being picked on for being trans. I saw a 15-year-old trans boy in the emergency department a little while ago who was thinking about suicide, had had a bad experience at school, and also had been planning a career in the military and had been hearing all these things about you can't go into the military, was just overwhelmed. And we had a good talk, his parents were there, we were able to sort it out. That being said, I think that a 30-year-old facing the same challenges would be less likely to be overwhelmed to that degree because of the greater life experience and coping skills. Maybe not, everybody's different. On average, that would probably be the case. That being said, again, why should he have to be put through that in the first place, I would ask. So younger people need family support, they need resources, they need health care, and also they need fertility preservation. The way to remember this one is that for purposes of trans health care, ovaries are mighty and testes are not. And what I mean by that is that trans boys who keep their ovaries do not have surgeries affecting their ovaries until later ages, and who take testosterone can stop testosterone and ovulation will usually resume. However, trans girls, if they take estrogen for more than a short period of time, often will not ever have sperm production sufficient to create a pregnancy without assisted techniques. So for youth, that's an area in which parents are often involved, looking ahead down the road as parents do, and saying, what do we need to do to keep your options open for when you're older if you want them? For people who transition at older ages, there's often a more extensive need for medical services, and some characteristics that developed with the first puberty cannot be changed, such as skeletal development. Your height is your height once those growth plates close. Social behavior may be out of sync with peers. A trans woman that I was speaking with who transitioned in her 60s said, I've always felt female inside. I never had the opportunity to transition when I was younger, so I'm doing it now. I'm thrilled. At the same time, I didn't go to girls' school. I was raised as a boy, and now I'm picking up different behaviors to fit in better with women my age. On the other hand, for some people, they might say, I'm different. I don't think it matters. You know, in the words of Popeye, I am what I am, and that's that. Often, fertility decisions have been made, adult coping skills have been learned, there's independence, people are not dependent on parents, and they may have some professional or other resources at their disposal. So there may be more life experience to draw from, and sometimes there's more to lose. At this point, I'm going to show a really short vignette because I realize in an audience this size, some people could give this talk better than I can, and some people probably have no experience at all in this area. So I'm going to give you one little vignette. This is just a half a minute or so of a trans girl of 12 explaining what this is about for her.
My name is Ariel. I am 13 years old and I identify as a girl. I haven't really experienced puberty at all. I mean, the hormone blockers are like my lifesaver, but me turning into a man is just probably the most horrifying thing ever I could ever think of. In the farthest reaches of my mind is me not going on the hormone blockers anymore and me developing into a man. That would just be horrible.
Okay. Every time I show that clip, I think, she's so much more appealing than I am. People are going to say, can we just watch the rest of that film? And yes, you could. You could go to the PBS website and find their frontline documentaries and look for one that was made about 1.5 years ago called Growing Up Trans, and you could watch the whole thing. Okay, so back to treatment and clinical things. For youth, pre-puberty youth, there are a lot of gender creative kids who are in some way different than their peers. They need space and time. They need parent and family support, and sometimes siblings need support too. In adolescence, the need for puberty suppression or suspension will usually become apparent pretty early in puberty. That being said, some youth will not really realize that they are trans until adolescence, and that's okay too. On the other hand, for kids who may be differently gendered but may not need a transition, could a trial of puberty as it would occur without any type of treatment be more appropriate? Sometimes there's a need for flexibility in this regard. Some kids will start puberty suspension, realize that that isn't for them, that they want to try going off it and let the puberty that they're biologically ready to have otherwise proceed, and that can be fine too. I've had someone say to me, well, isn't that a treatment failure? Didn't you pick the wrong kids? No. You know, in a lot of things in life, we have to try it to know, and either outcome, in my mind, would be a success. They need support navigating in a world that may not understand them and that they may not be entirely ready for. Their social development in many ways will be a challenge if they're not in sync with same-gender peers. They need support, their families need support, and if any other risks are occurring, like kids are dealing with feelings through substance use or depression, then that will need treatment too. That being said, we talk a lot about risks of youth. Many kids do very well, particularly with good family support. Their outcomes can be tremendous. For adults, it's a little different process sometimes for people who either didn't feel the need to or were not able to transition gender in youth. Sometimes psychotherapy is helpful in weighing options. Now what? I got this far, what am I going to do? That being said, the coming out process, which refers to first awareness to oneself, I'm trans, I need to do this, and then being public about it to others, is a process. And this is often a time of heightened emotional vulnerability. Sometimes that realization is gradual. Gee, I think this would fit me better. Sometimes it hits like a ton of bricks. Sometimes people may have been overcompensating. A good friend who works in the VA said that many of the trans women that he sees who did their active duty service while still living as men were decorated for bravery, volunteered for hazardous duty, did everything that they possibly could to appear the most manly and masculine that they could ever be, until one day it fell of its own weight and they said, who am I kidding? Not myself, and went and got treatment. A lot of vulnerability there. There are options, there are medical options, there are social options. Eli touched on a lot of those, and I won't go in to that further. As with any change in adulthood or at any time of life, some things will be lost and some things will be gained. Other people will see you differently. Once you come out as trans, that is a bell that cannot be unrung, even if you decide that you're going to go in some different direction with gender expression. The 5% rule, I don't have a source for, or I would give it to you. Basically, that says, I heard this from someone that I saw clinically, Allow people 5% of the total time that they have known you to totally get it right in terms of your preferred name and pronoun. So if someone's known you for 20 years, they're going to need to practice. They're going to be, make mistakes. Be gentle with them. Give them a whole year. If they've known you for 3 weeks, they get a day. Enough's enough. Relationships will evolve. Some partnerships will end. Some will not. Some will be richer. One of the things that I hear commonly from partners of trans people is, our relationship is actually better because she is more relaxed, more natural, more comfortable with themselves. Work may or may not work out. When I first started in this field in 1995, people who transitioned lost their jobs just routinely. It was awful. At this point, that's less common, but it still happens, and only 20 states have some reasonably robust protection from employment discrimination on the books, let alone how that is acted out. For older adults, there are a lot of different pathways. Some people transition at younger ages and then grow into older adulthood. Some didn't have the opportunity to transition earlier or didn't know that they needed to and are transitioning in their 50s, 60s, 70s, 80s. Coming out late can still be wonderful. For older adults who transitioned decades ago, they've left a legacy of hope for their younger peers, but often didn't really reap the benefits. Medical treatments are much better than they were decades ago. The social climate is much better than it was decades ago. These were the pioneers who made it better for everyone else. Many people find that living authentically is incredibly rewarding, but it brings with it authentic discrimination. One of the things that I hear commonly from trans women is they didn't really know, even though they were good, nice men, what women really went through until they walked that walk. Older adults also are more likely to be living stealth, i.e. not letting people know that they have transitioned if they transitioned a long time ago. Sometimes that can be cause difficulties later. Medical needs become more complex for older adults during and after transition. Many people who transitioned a long time ago, no one knows, no one where they're living now ever knew them in the other gender, are terrified. They're afraid of becoming dependent. They're afraid of needing dependent care. They're afraid of letting someone into an intimate world that they've kept to themselves and a few selected others, particularly someone who's not had any genital surgeries. The idea that a care attendant is going to see them exposed and possibly have all the negative reactions that Lola so eloquently talked about is very scary, and some have actually detransitioned, i.e. continued living gone back to living in the birth-assigned gender, even though it's not right for them, to try to avoid abuse in care facilities and home care and similar environments. Sometimes with dementia, people will at times forget about the transition and come up with material from earlier in life, similar to someone who speaks multiple languages losing all but their birth language, or someone who married and changed her name going back to her birth name. These are scary things for people. End-of-life planning and palliative care also have certain complexities. People in the older adult cohort who transitioned a long time ago are also less likely to have good social support and family support because family rejection was more common decades ago than it is now. Everyone's experience is individual, but this is a group that surely needs support. So how do we respond to this? This is teaching trans, and again, this is applicable to any health field, in my opinion. Principles of clinical inclusion are similar, regardless of the population, whether we're talking about women's health, the health of resettled refugees, or any other population, but the specifics are different, and we've spoken about some of those tonight. One of the things that I used to hear when I was in school was, well, don't make assumptions, which I think is based on a flawed assumption. In real life, we can do nothing else. You know, it's a proper function of the amygdala, which is the part of the brain that responds quickly to tell us if people are like us or unlike us and if there might be danger or not. That being said, we can then question our assumptions as humans with all these pesky neocortical structures that our animal friends don't have and ask whether the assumption is a good one or not. If we make mistakes, okay, apologize, move on, project welcome, and remain calm. I say that to my students, and then I say, or at least try to appear calm. You know, I can't tell you how to be. We can create a welcoming environment, post a non-discrimination statement, fix the restrooms, and also try to make up for some of the structural flaws, such as in electronic records. I try to keep a developmental perspective in my own work and in talking about it, because youth and adults and older adults often have different needs and different strengths, and to maintain a life cycle perspective because hormonal and surgical treatments and their follow-up require management over the lifespan in most cases. In addition, the process of transition itself can be overwhelming enough that other things like cancer screening and cardiovascular health don't get attended to adequately. Many programs are still very youth-focused and are not very helpful to older adults, and older adults also are more likely in some ways than their younger peers to have had really traumatizing experiences as trans people in healthcare settings. So I think sometimes we need to go the extra mile. Lola spoke about the contextual effects and the increased anxiety that the current climate has brought to many people's lives, and I concur. When I started out, this was considered sort of an orphan area. There weren't very many programs, there wasn't much interest. At this point, this is mainstream medicine, this is mainstream nursing, this is mainstream mental health care. It remains a specialty area only insofar as there needs to be additional dissemination of information and skills, and therefore it remains a focus of clinical research and teaching. That's all I got. So at this point, we've all talked for a long time. We now have time to hear from you. If you have a question, Michelle is coming around with microphones and we'll bring those. I'll also remind people while we have a minute that there is a tremendous presentation on the microbiome that Dr. Crothers is putting together that's coming right up, and I want to encourage you to do that one as well. So tell us who you are and what your question is. I see someone with a cowl and a mic. Go for it.
My name's Kathy, and I work as an X-ray technologist and ultrasound technologist here. And my question to you is, or my comment, and then maybe you have an answer. The biggest barrier I have is there's nothing in the patient's information unless someone has taken the time to write it in comments or something. So when I go to get a patient, I have what I have. I've had one experience that I knew of that fortunately went very well. And we went through it, but in radiography, we have to ask people of childbearing age, women, when's your last menstrual cycle and chance of pregnancy. And that can open a lot of things up. So if there has to be, I know there's places out there that there's what gender do you identify with, or your preferred pronouns, or your name, or whatever. Is the hospital going to be doing something like that anytime soon?
I'll give you my answer, and then I'm sure Eli, you have some thoughts too. The short answer is, all of us try so hard to do the right thing, and we're defeated by the robots, right? So there has been the need to make the electronic record here more user-friendly with regard to gender identity. First came up several years ago and has had committee meetings and this and that, and remains unresolved. One option is the banner. Many medical records, electronic records, have a space for sort of other information that you would see right away that could be anything. And I encourage people doing clinical work to just plain type in, patient's preferred name is Michelle and preferred pronoun is she, so that people will see it. But it's partly a clinician problem and partly an electronic record problem, and someday this will be history, but it isn't now. Eli.
So I don't have much more information than that. I did hear a rumor recently that the next time the hospital does a big update of the EMR, the record system, that there's going to be a patch that's put in that will include more information about a patient's preferred pronouns, gender identity, assigned sex at birth. So the rumor is that it's coming down the pipeline, but I don't know how soon that's going to be.
So I forget which electronic health record the hospital is on, but these fixes do exist. They just cost money to implement, and the hospital has known about this. It's been on the agenda for at least 10 years now, but I know that the patient navigators, and there's one in particular who works with the Trans Youth Clinic, who that committee needs to hear from people. So long story short, if you work in the hospital, that information needs to get up because it's just at the bottom of a list of a lot of things, and it seems to remain at that end. And what they're saying now is we need to hear from people, patients especially. If it becomes a patient priority, it moves to the top of the list. But if you work in the system, your voice matters as well. So there is some room for advocacy here to get that to bump up the list so that they could do it sooner than later, because the fix exists, we're just not doing it.
My information is a little different, but I think that letting the hospital know you'd like that is also useful. Another question? Who has the mic? Go for it.
Hi, I'm Dr. Marianne Wangeman, and I'm actually from the Washington, D.C. area. And one reason why I love these 2 weeks I'm spending in Vermont is because your universities open up discussions like this to the public, which we don't do in the Virginia, D.C. area very much. And it's just been wonderful being up here to be able to take advantage of this. So thank you for your time in presenting this topic. Specifically, I teach human resource development to mostly adults. So not necessarily undergraduates, more graduate type students and doctoral students. And this topic is extremely sensitive. And I start off with something as simple as the gender unicorn, thinking, how can you not love the gender unicorn? Because it helps to, it's cute, and it helps to just take a very difficult set of constructs and just lay it out very easily and nicely. And I'm amazed at the response of my students about the gender unicorn. It makes some people extremely uncomfortable. They start arguing with me about why we're presenting this to children, how do they know, and there's just a lot of anger, and they just don't know what to do with it. And I saw the flip side of a child that lived across the street from me who struggled with some of these issues and is Catholic, I'm Catholic, and the parents, as soon as he mentioned anything about this, would like race him up to the priest who would try to talk the fear of God into him. You know, I mean, it was horrible. And the kid did exactly what you talked about, tried to commit suicide because he just couldn't cope with all this. So I see a real value of this, but I don't know how to get to people who aren't exposed or aren't aware of this, because trying to start that conversation makes them very uncomfortable. And I almost wonder, we're starting to see these themes in television shows and in movies that were up for Academy Awards and those kinds of things, but people that are very against this don't go see those movies, right? Or they limit their viewing. So I almost feel like mainstream television has to stop identifying so much with, this is what a girl looks like, and these are the actions a girl takes, and these are the actions a boy takes, because I think that creates this artificial sense of confusion, which makes your lives a whole lot more difficult than they need to be. And I'm not sure where we go from here, and I'm just wondering what your thoughts are in terms of how can we start the dialogue? How can we get people involved? This is great, but I know a lot of people in my class would have never come to this. Thank you.
Well, we're going to send people out with nets and bring them in. I'm just kidding. I'm going to say one thing, and that is come talk to me afterward, because I know someone in your area who might be helpful, and then I'll turn it over to my colleagues here. Would you like to take that one?
Sure. When I was doing my graduate work in civil unions in 1999 in Vermont, one of the things that was very present was the hostility and anger that filtered in all different parts of the state as I did my field work. And it was sort of tilted in a strange direction. I remember going to a meeting of what I call the strong opposition of two, and walking into an armed security guard with a gun that was the size of my forearm, and asking them, why do you have a pistol? And they turned to me and said, well, you never know who's going to show up. And it was just incredible to me that there was that much fear and that much anger. That was 1999. Now, I'm not going to sit here and say that everything is all happy and well for gay and lesbian same-sex marriage. I don't think it is. But it isn't 1999 anymore. And I think part of the reason that happened is that more and more people who were hostile and who were separated from that part of the population began to notice around them people who were members of that population. And they began to look at their neighbors and their friends and say, wow, I didn't know that my friend Tom was gay, and I had no idea that Aunt Alice was a lesbian. And so it gradually became a little bit more normal, a little bit more normal for those people that you're referring to. I think the same is true with trans people. I think it's a slightly different road. It's one of the reasons that I chose to be as out as I can manage to be. I think that one of the differences that we're really talking about something that's much more visceral, something that is much more likely to be tangible and visible, as opposed to who do you love? Because you can ask that question of anybody in the room, and who knows what kind of answer you'll get. But you can look around a population and start to notice difference in a way. It's how humans are partly wired. We notice difference. So it's just that, the next step is to do the other things, like better medical care, that will make it possible for more trans people to be less afraid. And by being less afraid, we're more likely to step out into the bright sunshine. And then all those other people that are terrified of us and are angry at us will start to realize that, oh, there's more of them than I thought. And no, it's not a trans army, but there's more of us.
Who has the sacred microphone?
Right here.
Back there.
Hi. My name is Rex Budd. I'm the interim executive director at the Pride Center.
Sure.
And not that it's upon trans people to solve problems, but I have a question for the University of Vermont Medical Center. How likely is it if an assertive trans person were to say upon entry, look, I'm trans, I want you to put this on my banner so everybody sees and it's not buried in the notes. Is that likely to get them what they need in the way of a clear indication of who they are?
Speaking on behalf of the entire University of Vermont Medical Center, which I'm not prepared to do. I can only give you my personal opinion, and Eli, yours can weigh in as well. I think that if someone had that depth of knowledge and came in with that exact thing, it would probably happen. That being said, this is one of those things that, you know, a lot of people have a lot of difficulties with the electronic record, and this may not be something that they know how to do. But I think that that request would be met. I don't think that most, you know, physicians, nurse practitioners, other clinicians would say, no, I will not do that. That seems unlikely. Eli?
I think people would probably be open to it, and I'm not the most familiar with the EMR, but I think the big obstacle would just be figuring out where to put it. It's such a multi-headed beast that if you're logging in from an outpatient clinic versus an inpatient setting, if you're a nurse versus a respiratory therapist versus a medical resident, you log in and you see different things when you open up a patient chart. You start from a different place, you have a different home screen. So I think the real challenge would just be figuring out where in the chart can you put it where it's gonna be visible to everyone. And I don't know that we found a solution for that.
The banner's the best we have, but don't even get us started talking about the electronic record. I mean, honestly, you know, it's a thing. Michelle, are you bringing the mic around? How are we doing this? Okay, who has the sacred mic? Go ahead.
Hi, my name is Jordan Kelly. I'm a physical therapy student here at the college. My question is just about whether there are opportunities for physical therapists that you know of or are familiar with within the process of helping a person to transition or in the process of transition.
I can mention one thing and then turn it over to others. I, several years, have done a session with the doctor of physical therapy students, and the patient vignette that I show the video from that this trans man kindly made with me is someone who has a physical disability. And one of the things that he talks about is after his car accident, learning to walk again and so forth. And I think that PT has the wonderful aspect that it's hands-on and the downside that it's hands-on. And the thing that I can most suggest is, you know, bearing in mind that touch can be a difficult thing, particularly for people who have a history of gender trauma, you know, older adults who have had terrible experiences in healthcare and so forth. And so in some ways, the approach to take may be similar to working with other people who have had bodily trauma. You know, the ask questions, go slow, you know, project reassurance, be comfortable with people's resistance, that sort of thing. That being said, that's the one side. You may also see someone who's, you know, 18 and transitioned 3 years ago and comes in with a knee injury, and all they want is treatment for the knee injury, and they're out proud and it's fine. You know, it's a big world. Eli, do you want to hit that one, or anyone else?
I don't know that there are specific forms of gender-affirming physical therapy per se. I feel like from friends that I've spoken with and other patients that I've spoken with, the thing that I hear more commonly is, you know, I'm a trans person who happens to have a shoulder injury, and I don't know where to find a physical therapist who I know will be cool about it and not make a big deal about my gender. So I think just broadly being open and accepting and finding a way to make sure that that's clear in your practice is the most valuable thing you can possibly be doing. I do see a fair number of trans people who have issues with injuries or chronic pain related to stress and anxiety. So a lot of people with like neck or shoulder issues and things like that. And that might be the only generalization that I can make. But
I would just add, I do some somatic work around consent and touch. And it's very common for many people to have difficulty with touch. We are not a touch-based society anymore. But the other factor that I think shows up a lot more for trans people than I would call normal or expected is an overall body dysphoria. So I'll echo what Eli said in a practice that you do as a physical therapist. Helping them feel at ease with that would be my number one suggestion, and then going through the touch part.
It also wouldn't hurt to post something on the website or in the office or whatever saying, you know, everyone is welcome here, you know, and make it really clear.
Yeah, that's what I was going to say for anyone, no matter what your practice is also to think about the systems and your physical space. And even if it doesn't show up in your one-on-one interactions with folks, to know that they can go to your office and there's a bathroom they can use, or there's a place where they can change their clothes and have the privacy that they're looking for, or know that they're welcome there. And Eli said something earlier that really is staying with me, but that it's not good enough just to not be bad. And yet how many people we know that are just looking to not have a bad experience. Like, they're not looking for you to be like the most amazing provider of their care and know all the answers. They're just looking to not have a bad experience. And I think that's an incredibly low bar, and if we can't meet that, then we're still in pretty serious trouble. But at this point, I like to think we can, and we can do better. But if we could at least meet that, we'd be really doing a lot for folks.
There are a few questions down here. Do you have the sacred microphone? Yeah, or even the plain old one.
Hi. The electronic medical record is a beast no matter where you are, and many changes still to come, I hope. But I'm more interested in the human beings who work in University of Vermont, the medical center, the medical school. Are there specific steps that faculty, administration, human resources are taking to help people who work in these settings do some mind bending and develop some cultural sensitivity, and I would hope cultural competence around many different populations, but specifically tonight, the trans community and the LGBTQ community?
I'm talking a lot here, but I'll talk a little bit more and then invite my colleagues as well. In terms of the cultural competence aspect, personally, I kind of prefer the term cultural knowledge, because cultural competence sounds like we're competent or we're not, and for any of us, it's an ongoing process of learning. And one of the things that I enjoy about being in a medical center is that there are presentations on a whole variety of population health things, global health, resettled refugees, trans people, et cetera. And, are we done yet? Absolutely not. Is there a lot going on? Yes, there is. I do grand rounds in various departments. A number of us teach in various departments. There are things going on. Not as comprehensive as I would like, but other things are not either. I really would like to see more on resettled refugee health, and again, there's some, but it's an ongoing process. Other folks?
Most of what I see happening around trans cultural familiarity and knowledge specifically is not happening on an institutional level so much as on a departmental level. So I think I was having a conversation with someone a few weeks ago about what it would take to get some kind of mandatory trans-related training for all of the staff in the UVM Medical Center system. And there's so much mandatory training that they have to go through that getting something like that in there is really challenging, and it would have to come from a really high level. But I see a lot of departments saying, you know what, we're going to have a grand round session that deals with trans health, or we're going to have at one of our clinic staff meetings, we're going to have someone come and talk about trans health, and it's coming from the ground up in that way, which the side effect of that is that different parts of the hospital and the medical center system can have really different levels of training and background. So I would like to see something come down from higher up.
I'll also mention too that the medical school curriculum has a total of 37 hours of LGBTQ health related material over the 4 years, and someone would say, well, 37 hours, that's not much. I mean, that's in addition to clinical exposure, but that's a whole lot more than many other population related health concerns. Sacred microphone.
Hi, my name is Betsy. I'm a lead operator at the hospital switchboard.
Oh, how nice.
So I talk to the two of you a lot. And I really appreciate what Eli just said, because it's exactly what I'm going to talk about. I think we're often, very often, the very first people that a patient will talk to when they're calling the hospital for some kind of help, whether it's just to get an appointment or whatever. And I think we have a unique opportunity to maybe do better in this area. So as a lead operator, I'm going to make this my project for this year, so you're going to hear more from me. But especially after hours, at night and on the weekends, we do patient messages for the dozens of offices. And there should be a way that we can include these questions of, preferred name. We have to get the legal name in there, I would love to work with the two of you to be able to work on some scripting, because we have a lot of operators and some of them just have high school education, so we really need to have things very specific and very scripted and want to make sure that we get it right. But I think that this is the kind of grassroots thing. That's what's really going to help people, and top-down doesn't usually work very well.
I'll mention that the endocrinology department redid their staff training after there was a difficulty with a patient who was trans, and the receptionist that he was speaking with on the phone was brand new. It was not her fault, but it didn't go well, and they had to say, what are we doing? And the other thing that I would say is it's such a pleasure to meet you, and it warms my heart that you have this concern. That's excellent. Yeah, Eli.
I would be really excited to talk with you more about what that might look like and what kind of systems we can put in place there. And I just wanted to say that I love the point that you made about kind of being on the front lines in terms of contact with patients. I used to work as a medical assistant, and I was thinking at one point, we focus so much on cultural familiarity for providers, for the doctor, but we often don't think about everyone else that the patient is interacting with. And in the clinic where I worked as a medical assistant, there might be 5 or 6 other staff that the patient interacts with before they're back in a room with the doctor. And if those people aren't familiar and comfortable with what they're doing, that has almost a bigger impact on people's experience than the interaction they have with the doctor. So it's really exciting to see people in other roles who are excited about finding ways to approach that.
And get your supervisor's permission before you go running ahead. I'm just saying. All right, another question.
Hi, I'm Megan, and I'm a first-year medical student, and I have 2 questions. One of them is for adolescents coming in who are trans, whose families may not be supportive. How do you provide support to them and to their families and manage the legal problems of being a minor seeking health. And then I have another question about estrogen and testosterone and complications that could happen. I know in pregnancy, when people are going through hormone changes, there are some other complications that could happen. Are those things that we're concerned about, or are they more minor that we don't treat those, or how does that work?
I have my answer. Do you want to lead off? Yeah, we're getting a lot of medical-y questions. I mean, it's medical school, but we also have other folks here.
So starting with the second question about side effects of hormones, it's a complicated story, but a lot of the side effects that we see are kind of the same things that we see in cis people that are related to hormones. So we know that, in cis women, when they have a physiological state with higher levels of estrogen, there's also a higher risk of deep vein thrombosis. And guess what? That's what we see in trans women who start taking estrogen. We know that in cisgender men, higher levels of testosterone are related to things like an elevated hematocrit or worse blood lipid profiles, and we see those changes in trans men who start taking testosterone. So it's kind of, people talk about cardiovascular risk in trans men and saying, when you start taking testosterone, your cardiovascular risk level increases to what you would see in a cisgender man. So a lot of the side effects are kind of along those lines. And then I'm so sorry, jog my memory about the first part of your question. Adolescence. I might let Dr. Eiler handle that one because you have a lot more experience in that area.
I'm going to tell you one anecdote from a listserv. So this is getting people's opinions from around the country that illustrates this dilemma. One person posted on the listserv and said, hi, I'm a therapist in, I don't recall the state, but it's not one that's known for its progressive stance towards trans people. And I'm seeing this adolescent, and the parents don't want any, are opposed to the youth transitioning. At the same time, the person that I'm seeing clinically is getting more desperate, and I'm trying to walk the line of bringing the parents in because I don't want them to end this clinical relationship, because then this young person will have no support at all. And so I'm really trying to negotiate this. And in jumped several other therapists, we're all typing at each other these days, who were on the West Coast in progressive communities, who said, that's ridiculous. Just talk to them and say they have to do this. Kids have rights too. Really. So I'm only saying that, this is something that goes forward in fits and starts, and that one of the things that I see is even within our larger catchment area, there are big differences. One of our recent child psychiatry fellow grads had been treating trans youth in the clinic here and not having a lot of difficulty. Went into practice across the lake in a small community, and the first trans youth that crossed the threshold of his office, basically the parents were there saying, how can you get our child to stop this? So there are some really thorny issues here, because the fact of the matter is, if there's someone who's the same at Ariel's age, parents exert a lot of authority, and that's sometimes really helpful, like saying, yeah, you are gonna bank sperm before you start estrogen, because we don't know what the future holds, and I'm looking after your future interests, and I want you to have the opportunity to have children later if you want them. And sometimes it's difficult, and there's not an easy answer on that one.
I would just add, from a systems perspective, knowing the laws in your area, like Evan said, coming from California, it's dramatically different what healthcare youth can access on their own without parent consent than it is in some other states. And it's helpful to know that when you're advising them. It's also helpful to know things like when someone's legal name is going to show up on their insurance bill, and that bill is going to go home. And that's something that we deal with a lot on campus. For students who aren't necessarily out to their parents, or they're out but their parents don't know they sought hormones, or any nuances there. We do a lot of education with the students to help them understand when legal name is going to be used and where it's going to show up all along the process, so that it's not a surprise and it's not some kind of outing situation for them.
One more question.
One other thing that
and
you
one more
can
answer.
do in supporting youth, because I've noticed this a lot. I haven't had to actually be that provider. I think that sometimes the people that really need the treatment are the parents, but it's just parenthetical. I find that sometimes parents benefit from having support that is completely outside of the system in which the trans child is immersed. That is to say, referring them to you or referring them to the doctor, nothing wrong with that. But sometimes there is a sense of comfort if they feel like there's somebody else outside the system who can look in the way they're looking in and help them figure out what to do. So support for the parents is another way if you can reach them.
If we'd had another hour, I would have talked more about parent issues. You know, I mean, the number of really wonderful parents who will say, I'm doing the best I can here, I love my child, I'm supporting the transition, and I'm also grieving the child I thought I had. You know, the gender of the child that I thought that came out backward, the child's gender that I thought would be there. I would encourage you to go to pbs.org and watch the thing on trans youth. It really is good. One more question, and then we have to. Sure. And one more answer.
Really quickly, and I think this is relevant to everyone who might be interacting with a trans kid, and not just people from a healthcare provider perspective. Regardless of where parents are at and what's going on with parents, I think it's so important for trans kids to know that there's one adult out there in the world who believes them. And even if you can't do anything else for them, even if you're never going to see them again, being able to say, I know that your parents are having trouble with this, but I believe you. There's nothing wrong with you, can really go a long way. And if you're in a position to help them kind of build capacity around identifying other supportive adults in their life, so much the better.
Amen. We're about to be thrown out of the room, so we're going to have one more question from the wonderful Mike and then stop. I'm seeing one hand down here that has come up a couple of times, or many.
I was a dermatologist in Rutland, and about 35 years ago, Dartmouth Hitchcock Medical Center came out with a problem-oriented record, and I adopted and found, for the problem that was discussed a number of times tonight, the fat chart, that it was extremely helpful. A page goes on the front of the chart and includes the medications that are being taken, adverse side effects, any problems medically, but pertinent history and social history in particular, and in a case like this, sexual orientation and operations.
You know, I totally agree, and we need to do more in that. And I will also just mention that particularly for older adults, but many younger ones as well, some people are not ready to disclose that information for all the reasons that we spoke about, and that we also need to create the environments where people will feel safe doing that. That being said, I agree with you that if something is buried on page 42, it's not very helpful. Other comments?
Yeah, I mean, I think to a certain extent, things like a patient's preferred name and pronouns are basic patient identifying information, and we really do providers a huge disservice by not making it easy to identify that information in the chart for trans patients. I was talking with a faculty member here the other day who's a wonderful doctor and has been practicing for quite a while, and he did not know that I'm trans and did not know that this was an interest of mine, but pretty much out of the blue commented, you know, the number one way that I worry about offending or upsetting a patient is that I worry about getting a trans patient's pronouns wrong, because when I look at their chart, I have no way of knowing. And it's such an easy, it should be such an easy problem to prevent.
I just want to end by thanking everyone for coming, and I think my colleagues would, I'll never hear the end of it if I don't make a plug for the Translating Identity Conference, which is a tremendous resource in the Burlington community. It's hosted by, it's a traditionally been a student-led conference hosted on the UVM campus. It's a day long, it's free, it's been happening for many, many years, and it's focused on trans community, trans identity. Everyone is welcome. There's a point throughout the day for everyone to engage where you're at, find out more, learn something new. So, and that's always right around Halloween. So that'll be happening in the fall of 2018, and it's TIC, uvm.edu/TIC, Translating Identity Conference. So if you want to know more, please come. It's all kinds of audiences, everything from medical transition to space for gender creative kids. So it's a tremendous resource, and if you want to learn more, hopefully we'll see you there. Thank you.
And don't forget the microbiome community medical school presentation that's coming soon. Thanks, everybody, very much.